Hello everyone, welcome to the Pathology series by ISU. My name is Ella Fernandez and I'm a student of LFHK, and I will be discussing the first part of the GIT system. In this video, we will be talking about the oral cavity, salivary glands, esophagus, and stomach. So let's begin with the oral cavity. Within this section, we will be talking about aphthous ulcers, herpes virus infection, oral candidiasis, AIDS and Kaposi sarcoma, as well as benign and malignant tumors of the oral cavity. So, aphthous ulcers are also known as canker stones, and they are small, rounded, painful, superficial erosions covered with gray or white exudate and have an erythematous ring. So that's a lot to take in, so we can go over it again. They are small, rounded, painful, superficial. SRPS. Small, rounded, painful, superficial. These aphthous ulcers can either occur singularly or as a group, and is commonly found within the first 2 decades of life. The etiology of aphthous ulcers is unknown. However, it is triggered by certain situations like stress, fever, some foods, specifically spicy or sour foods, or some type of autoimmune disorder. Aphthous ulcers tend to be self-limiting, usually takes around 2 to 3 weeks to heal on its own. Recurrent aphthous ulcers can be seen in Behçet syndrome. So what is Behçet syndrome? It is an immune complex mediated vasculitis, specifically of small vessels. And we usually see Behçet syndrome after a viral infection. So how does it present? It represents itself as recurrent aphthous ulcers, genital ulcers, and uveitis. We can think of it as the 3 U's. Ulcers, uveitis. So next we can talk about herpes virus infection. The herpes infection is extremely common and is caused due to HSV1. When it affects the oral cavity, it is known as herpetic stomatitis, and it is transferred from person to person. So in terms of primary infection, patient remains mostly asymptomatic and does not show any signs or symptoms of herpes infection. And this virus stays dormant within the trigeminal ganglion. However, it can reactivate. Reactivation is usually due to fever, changes in temperature, or even trauma. Once reactivation occurs, we have herpes infection. So how does it present? It presents itself as solitary or multiple vesicles containing clear fluid. And where is it? They tend to be around the lips and nose. These vesicles heal within a few weeks. However, if herpes virus infection persists or there is an increased recurrence, then we can treat with antiviral agents. Within immunosuppressed patients, not only do they have herpetic stomatitis, but they can also present with herpetic gingivostomatitis, which basically means that not only do they have these vesicles around the mouth, but they have it within the oral cavity as well as the pharynx. These immunosuppressed people can also present with lymphadenopathy. So in terms of morphology of herpes virus infection, there can be edema, which can be intra and intercellular. They can have intranuclear viral inclusions as well as giant cells. And the way by which we can diagnose it through pathology is using zinc staining, which is a specific stain for HSV virus. So next we can talk about oral candidiasis. Oral candidiasis is caused due to Candida albicans, which is actually part of normal flora of the oral cavity. So it is only pathogenic in patients that are immunosuppressed. So example of immunosuppressed patients are patients with diabetes mellitus, patients on corticosteroid therapy, patients with AIDS, cancer, anemia, etc. So oral candidiasis is the most common fungal infection of the oral cavity, and it presents itself as white plaques with erythematous base, and in severe cases, ulcerations may also occur. Candida albicans not only stays within the oral cavity, but it can spread. And when it spreads, it can spread to the esophagus, or it can disseminate via blood to visceral organs. In these situations, we need to provide the patient with quite aggressive therapy. So AIDS and Kaposi sarcoma. So AIDS tends to be associated with a lot of oral lesions, as I've said before, candidiasis, hepatic vesicles, but also glossitis, which is inflammation of the tongue, and gingivitis, which is inflammation of the gums. Along with that, patients with HIV/AIDS can also present with hairy leukoplakia, which is caused due to EBV. So what does it look like? Hairy leukoplakia are basically white patches with hairy looking surface, and this surface is due to epithelial thickening. And hairy leukoplakia is important to remember because it is very specific for patients with HIV. In Kaposi sarcoma, we can also see oral lesions. Half the patients with this sarcoma have purpuric discolorations, which clinically look like purple colorations or dark red colorations within the oral cavity. And not only do we have discolorations, but they can also be raised nodular masses. So now we can talk about some of the tumors of the oral cavity. Specifically in this slide, we'll be talking about the benign tumors. So the most common benign tumors of the oral cavity are squamous cell papilloma, fibroma, and pyogenic granuloma. Squamous cell papilloma are tumors lined by squamous cells, and they tend to be found on the palate and the uvula. And usually we have to resect these tumors. There can also be fibroma, which basically occurs due to chronic irritation, which results in hyperplasia, which then results in nodular fibrosis of tissue, which eventually leads to a fibroma. And the most common location that we can have fibromas is buccal mucosa. And then we have pyogenic granuloma, which is pedunculated masses in the gingiva, which is basically the gums. And these tumors tend to be richly vascularized and can also be ulcerated. These tumors can naturally regress on their own, or they can further develop into ossifying fibroma, which is the same as a regular fibroma. However, ossification occurs, so you can have bony change, essentially. So in terms of malignant tumors of the oral cavity, the most common one that is seen is squamous cell carcinoma. These cancers mostly occur in elderly, and it is quite rare to see patients below the age of 40 with squamous cell carcinoma of the oral cavity. Some typical sites are the lower lips, soft palate, base of the mouth, and lateral part of the tongue. So there are many risk factors that can cause squamous cell carcinoma. Some of them are leukoplakia and erythroplakia. So leukoplakia is basically a whitish mucosal patch or plaque, and is caused due to epidermal thickening or hyperkeratosis. What is interesting about leukoplakia is that it cannot be scraped off. And leukoplakia tends to be strongly associated with smoking tobacco, as well as chronic irritation due to friction. So, for example, in patients with dentures or patients consuming irritating foods. Erythroplakia is essentially the same as leukoplakia. However, there is no keratinization, so they aren't white. They appear as red. Other risk factors for squamous cell carcinoma are smoking and chewing of tobacco, HPV virus, and alcohol abuse. So these tumors are moderately differentiated keratinizing tumors, and they present as local pain, dysphagia. But other than these two findings, they're mostly asymptomatic. And because they're asymptomatic, the lesion tends to be ignored. So diagnosis occurs at later stages. sometimes when there's already been a spread. In terms of spread, it spreads to regional lymph nodes, especially if the cancer is on the floor of the mouth. In terms of prognosis, the best prognosis is tumors of the lower lip, and the worst prognosis if the tumor is on the tongue. So now that we have covered oral cavity, we can move on to the salivary glands. Here we can talk about cysts, silolithiasis, sialadenitis, and benign and malignant tumors of the salivary gland. So in terms of cysts, the common cysts that we see in the salivary gland are retention cysts. So what is a retention cyst? A retention cyst basically occurs due to obstruction of a duct. So obstruction of a duct within the salivary gland. When there is an obstruction, saliva that is constantly being secreted cannot escape, and that is what leads to dilation of this duct. And these dilations can eventually lead to cysts. So now that we know what retention cyst is, we can talk about the two types of retention cysts. There is mucocellae, which is retention cyst of small salivary glands, and we have ranula, which is retention cyst of large salivary glands, for example, sublingual gland. These ranulas tend to be larger than mucocellae, and most of them occur beneath the tongue. Sialolithiasis. So sialolithiasis is stone formation in salivary glands or in the duct that drains the gland. If it is in the duct, we call it sialodocholithiasis. So we can have acute or chronic. In acute, the duct is obstructed by the stone. There is retention of saliva in the gland. There is expansion and dilation, which eventually leads to pain. Sometimes, instead of having just one stone, there can be multiple tiny stones. And in this case, we call it sludge. So in terms of chronic sialolithiasis, we have replacement of the parenchyma by fibrous tissue, which occurs over time. This leads to sialadenitis, which is inflammation of the salivary glands, and we will talk about it more in the next slide. But sialadenitis over time leads to dysfunction of the gland and therefore leads to excision. So sialadenitis is inflammation of the salivary gland, and it can be traumatic, it can be viral, it can be bacterial, or it can be of autoimmune origin. So as I've said before, it can be caused due to mucocellae, and as we've discussed what it is, I won't talk more about it. Sialadenitis can also occur in patients with mumps. Mumps is caused due to paramyxovirus, and it presents itself as enlargement of major salivary glands, diffused inflammation of these glands, as well as possibility of edema and necrosis. In adults, not only do they have sialadenitis, but they also have pancreatitis and orchitis. Another cause of sialadenitis is bacterial sialadenitis, which is commonly secondary to an obstruction and less commonly due to retrograde entry of bacteria. So when they say retrograde entry of bacteria, it means that bacteria from the oral cavity goes through the duct to the salivary gland, and usually it occurs in patients who are extremely dehydrated. So the most common pathogens in bacterial sialadenitis are Staph aureus and Strep viridans. And in sialadenitis, not only do they have inflammation, but you can also have areas of necrosis or abscess formation. In chronic sialadenitis, there is a decreased production of saliva with inflammation. And in terms of the cause of chronic sialadenitis, it can be autoimmune. It can be Sjogren's syndrome, which is an autoimmune disease that specifically targets glands, and it commonly presents with dry eyes and dry mouth, or Mikulicz syndrome. Mikulicz syndrome is a combination of salivary and lacrimal gland inflammatory enlargement, and it is caused because of sarcoidosis, leukemia, or lymphomas. So now we can move on to the tumors of the salivary gland. In terms of benign tumor, we have pleomorphic adenoma. But before we talk about pleomorphic adenoma, it is important to know that most tumors that occur in major salivary glands tend to be benign, and those that occur in minor salivary glands tend to be malignant. Therefore, these benign tumors can be seen commonly in the parotid gland, which is a major gland. So pleomorphic adenoma is a mixed tumor commonly found in the parotid gland. They are benign and slow growing, and they're well encapsulated. They tend to be painless but can cause swelling and can be easily palpated. Usually, we need to resect these tumors, often removing also some healthy tissue in order to prevent any recurrences. For morphology, these tumors are encapsulated, and it has cells from ducts, acini, tubules, and all these cells are interspersed in myxoid stroma. Along with all of this, it can also contain islands of cartilage and maybe sometimes even bone. So you can see now why we call it a mixed tumor. Another benign tumor of the salivary gland is papillary cystadenoma lymphomatosum, but we call it Wharton tumor. These are a lot less frequent than pleomorphic adenoma. They are benign tumors, specifically only in the parotid gland, and they arise due to salivary tissue trapped within lymph nodes during embryogenesis. And the risk factor is cigarette smoking. In terms of morphology, they are small, well capsulated, rounded, with mucin-containing cystic spaces. Spaces are lined by 2 rows of pycnotic nuclei, and the epithelium has lymphoid stroma with germinal centers. So in terms of malignant tumors of salivary gland, majority of the time, a primary benign tumor can basically transform into its malignant counterpart. However, the most common primary malignant tumor is mucoepidermoid cyst. It's composed of a mixture of cells. It has squamous cell, mucus secreting cell, as well as intermediate cells. And it is caused due to abnormal chromosome rearrangement involving the Notch pathway. Usually, they are low grade. However, if they are high grade, they tend to be invasive and very difficult to excise. If the facial nerve is affected, which means that if the facial nerve runs in the area the tumor is present in, the patient experiences facial pain. So now that we have gone over the salivary gland, we can move on to the esophagus. Within this section, we will talk about congenital malformations of the esophagus, anatomical and motor disorders, as well as esophageal tumors. So in terms of congenital malformations, we have many. Here we will talk about atresia. So atresia is the absence of segment of esophagus, which is usually replaced by fibrous tissue. Sometimes it is accompanied with connection with trachea. So basically, it can form a fistula. And the most common fistula is a tracheal esophageal fistula. And this fistula can cause a variety of symptoms. So maybe we can draw and better understand what this looks like. So we have our atresia. So this is our esophagus with our fibrous tissue. And this is our fistula connecting the entire system to the trachea. So we can think of this as our fistula reaching the trachea. So when we consume food, there's no space for it to go through. So it is vomited back out. So one of the presenting factors of atresia and fistula formation is reflux vomiting. Other than that, consumed food can also go into the trachea, which means it can go into the bronchial tree, which causes aspiration of food. Along with that, there's also abdominal distension, which is common in children, which is when air from the trachea goes into the esophagus. And then we have polyhydramnios. So when you have a fetus, they are in the amniotic sac. This amniotic sac is made up of amniotic fluid, which consists a lot of it consists of urine. And physiologically, fetuses consume and swallow this amniotic fluid. In cases with atresia, the fetus cannot swallow this amniotic fluid, which results in excess amount of fluid inside the sac, and that is what we call polyhydramniosis. So other than atresia, we also have stenosis and stricture. Stenosis is basically narrowing of the esophagus, and it can cause dysphagia as well as difficulties with feeding. These strictures can be congenital, or they can be caused due to secondary causes like tumors, compression from structures outside like lymph nodes and aneurysm, or systemic sclerosis of the esophagus itself. Stricture is basically a subtype of stenosis which occurs due to scarring. So it is constriction by scarring, and the causes of it are ingestion of corrosive substances like acids and toxins, and the healing is what causes the scarring stenosis, which is what we call stricture. Another congenital malformation is diverticulum, which is the outpouching of mucosa due to muscle defect. It is important to know that this diverticulum is not a true diverticulum, because in a true diverticulum, the entire wall protrudes, but in this case, only partial part of the wall protrudes. In fact, most GIT diverticuli are not true, they're false diverticuli. So in diverticulum of the esophagus, there tends to be stasis of food. Because food stays within these outpouches, it can lead to a bacterial infection, leading to inflammation and eventually diverticulitis. What's important to remember is that diverticulitis can also perforate, which can then spread this infection to the other organs. Some common sites for diverticulum formation are the pharyngoesophageal junction, also known as Zenker diverticulum, and the defects occur dorsally. It can also occur near the midpoint of the esophagus, where the trachea bifurcates, and in this case, defects will occur ventrally. Or it can occur at the level of hiatus. So now we can move on to anatomical and motor disorders. So we can talk about achalasia. Achalasia is a disorder of motility because of failure to relax of the lower esophageal sphincter, and it presents as aperistalsis, which is the lack of peristalsis and movement of food through the esophagus, partial or incomplete relaxation of the sphincter, and increased tone of sphincter. Now, we can have achalasia due to primary or secondary causes. In primary, it's usually due to loss of innervation of the lower esophageal sphincter. And in secondary, it can occur due to, for example, Chagas disease, which causes destruction of the myenteric plexus, or it can occur as a complication of long-term diabetes, causing neuropathy. So in achalasia, there's progressive dilation of the esophagus, as well as either thickening or thinning of the wall. And inflammation occurs due to stasis of food. The patient experiences progressive dysphagia, regurgitation, aspiration, and bad breath. An interesting fact is that we can see achalasia on barium swallow as a bird beak sign. And achalasia can progress to squamous cell carcinoma. Next, we can talk about esophageal web. So these webs are thin protrusions of esophageal mucosa, mostly in the upper part of the esophagus. They're most commonly seen as part of Plummer-Vinson syndrome, which is characterized by severe iron deficiency anemia, esophageal webs, and beefy red tongue due to atrophic glossitis. Patients with these webs present with dysphagia, and they have an increased risk of squamous cell carcinoma. We can also have hiatal hernia. And basically, this is a dilated segment of the stomach that protrudes above the diaphragm. And you have two kinds. There is axial or sliding, or non-axial and paraesophageal. So let me draw here. Hopefully, the drawing is not terrible. So, okay, not bad. So this is the stomach. So in terms of axial or sliding hernia, basically the stomach mucosa slides upward into the esophagus, which is what causes the bell-shaped dilation. So you have it here. In paraesophageal, if this is the diaphragm, you will have a portion of the stomach protruding into the thorax through this diaphragm. So it will occur somewhere next to the esophagus. An interesting fact is that in paraesophageal hernias, you can actually hear bowel sounds at the lung fields. So now we can talk about Mallory-Weiss tears. So Mallory-Weiss tears are basically longitudinal lacerations at the esophagogastric junction. And this lacerations is usually due to excessive vomiting, which can either occur due to chronic alcoholism or some type of psychological issue like bulimia. With time and with severe lacerations, patient can also experience painful hematemesis. And there's also a risk of Boerhaave syndrome, which basically is the rupture of the esophagus leading to air in the mediastinum and subcutaneous emphysema. In these patients, you can hear crackling sounds when you palpate them, and we call this crepitus. Another anatomical and motor disorder is varices. So the esophagus is one of the communication sites between splanchnic and venous circulation. So when there's an increase of pressure within this plexus of these two systems, it can cause dilation of the vessels. And in this, and in varices to do with esophagus tend to occur in the distal esophagus and proximal stomach. Usually patients with cirrhosis experience varices in this area. There's a risk of rupture, hematemesis, and hemorrhage with esophageal varices. Now we can talk about GERD. So what is GERD? GERD is gastroesophageal reflux disease, and it's basically reflux of acid from the stomach due to a reduced sphincter tone. There are many risk factors, but the most important are alcohol, tobacco, obesity, fatty diet, and caffeine. Patients present with heartburn, coughing and asthma, usually damage to teeth, ulcerations and strictures, and narrowing of lumen can also occur. And it is a risk factor. GERD is a risk factor for Barrett's esophagus, and we will discuss more about Barrett's esophagus later. So we also have esophagitis, which is basically just the inflammation of the esophagus. There are many causes of esophagitis. Some of them are prolonged intubation, corrosive substances, chemotherapy, uremia. It can also be reflux esophagitis, which is basically abdominal contents going back up into the esophagus. And now this does not necessarily mean that it is just the stomach juices or fluids. It can also be gas that goes up, and is common in Western countries, and heartburn is the main symptom. There are also other factors that can cause esophagitis, like alcohol, tobacco exposure, hernias, increased gastric volume, just to name a few. Other than heartburn, patient can also present with bleeding, stricture formation, and esophagitis is also a risk factor for Barrett esophagus, and we will talk about that more later. Esophagitis can be mild, in which the patient will just have hyperemia, so there will just be red coloration and some inflammation of the esophagus, or it can be severe, in which the patient has erosions and ulcerations of the esophagus. In terms of morphology, patients tend to have loads of eosinophils with or without neutrophils. There is a basal zone of hyperplasia and elongated lamina propria papillae. So now we can talk more about Barrett's esophagus. Barrett's esophagus is metaplasia of the lower esophageal mucosa, from stratified squamous epithelium to non-ciliated columnar epithelium with goblet cells. That's a lot to take in, so we can go over it again. It is the metaplasia of the stratified squamous epithelial tissue present in the lower esophagus to non-ciliated columnar epithelial cells with goblet cells. Barrett's esophagus is seen in 10% of patients with GERD, and it results from acidic stress in the area, and it can progress to adenocarcinoma. So now I can understand that it's difficult to differentiate between GERD, esophagitis, and Barrett's esophagus. So we just need to remember that GERD is caused due to reflux of acid due to lower esophageal sphincter tone. Esophagitis is caused due to various things, not just the lack of tone, but it can be caused due to a variety of etiologies. And Barrett's esophagus is basically what occurs with long-term GERD and long-term esophagitis. So I hope that makes things a bit clearer. So now we can talk about esophageal tumors. In terms of esophageal tumors, the malignant tumors are more prominent, and therefore we will be focusing just on the malignant tumors rather than the benign. So malignant tumor, we can talk about squamous cell carcinoma. It is common in the upper third and the middle of the esophagus. Some risk factors for squamous cell carcinoma is esophagitis, achalasia, Palmer-Vincent syndrome, alcohol, tobacco. Along with these risk factors, there can also be genetic involvement, like mutations with P16 and INK4 or P53, which are the more important ones. So what happens is that you have epithelial dysplasia, which eventually leads to carcinoma in situ, which eventually leads to an invasive carcinoma. In early days, this tumor is small, gray or white plaque, or it can be elevations in mucosa. So we can go over that again. It can be small, gray or white plaques, or it can be some areas of elevation on the mucosa. In later stages, there can be three forms. You can have polypoid exophytic masses, necrotizing cancerous ulcerations, and diffuse infiltrative neoplasms. So polypoid exophytic masses are masses that will go outside the mucosa, necrotizing cancerous ulcerations, which will embed and excavate into the mucosa, and we have diffuse infiltrative neoplasms, which will most probably be flat. In terms of metastasis of squamous cell carcinoma, because they occur in the upper third and the middle of the esophagus, it can spread to regional lymph nodes, in this case cervical and mediastinal lymph nodes. Another tumor of the esophagus is adenocarcinoma, and this is most commonly seen in the lower third of the esophagus. Barrett's esophagus is usually the precursor for adenocarcinoma. So Barrett's esophagus causes an increased amount of cell proliferation, which causes an increased risk for chromosomal abnormalities and high-grade dysplasia. Other than Barrett's esophagus, there's also genetic predisposition with people with mutation of P53, beta-catenin, and HER2/neu. Initially, they are flat or raised patches, and later these tumors become large and nodular. They can be ulcerative or diffused. So they're very similar in terms of presentation to the squamous cell carcinomas of the esophagus. Patient presents with dysphagia and obstruction, weight loss, anorexia, as well as general fatigue and pain. And metastasis occurs again in regional lymph nodes, and as this is in the lower third of the esophagus, in this area, it is the celiac and gastric lymph nodes. So now we have finally finished the esophagus and we can move on to the stomach. So in this section, we will be talking about gastroschisis and omphalocele, pyloric stenosis, gastritis, gastric ulceration, and gastric tumors. So gastroschisis is basically a congenital malformation of the anterior abdominal wall leading to exposure of contents. So what does this mean? It basically means that the anterior wall of the fetus is almost not present, and therefore there's exposure of the GI organs. So the intestines and the stomach are all exposed and can be seen. Omphalocele is the herniation of bowel into the umbilical cord. Usually, the bowels go from the umbilical cord and retract into the space that they're meant to go to. However, due to failure of these intestines to return to the body cavity, we have omphalocele. The contents tend to be covered, unlike gastroschisis, and here they're covered by peritoneum and amnion of the umbilical cord. There's also pyloric stenosis. Pyloric stenosis can be congenital hypertrophy of pyloric smooth muscle. It is commonly seen in males, and it is usually seen after the first 2 weeks of birth. These patients have difficulty with feeding, vomiting. You can also see visible peristalsis as well as olive-like masses in the abdomen. Pyloric stenosis not only is congenital, but it can also be acquired due to some type of tumors or stricture formation. So in terms of gastritis, we have acute gastritis and we also have chronic gastritis. So in this slide, we can talk about acute gastritis. So acute gastritis, which is acute inflammation of the stomach, tends to be transient and usually accompanied by hemorrhage or erosions. The pathogenesis is not fully understood. However, it is commonly associated with heavy use of NSAIDs, alcohol, chemotherapy, and shock, and less commonly associated with uremia, corrosive substances, trauma, etc. But it is important to look at the common causes, so NSAIDs, alcohol, chemotherapy, and shock. So we can talk a little bit about why they cause acute gastritis. So NSAIDs basically decrease the amount of prostaglandins. And why are prostaglandins important? So prostaglandins increase blood flow to the stomach, they decrease the acid production, and they increase secretion of mucus and carbonate. So when we have less prostaglandin, there's less blood flow, there is increased acid, and there's decrease of mucus and bicarb, which means that there's an imbalance of protective and damaging factors, where in this case the damaging factors are increased and the protective factors are decreased, therefore causing risk for acute gastritis. Now you might think, why is blood flow important? In this case, blood flow is important because if by some chance toxins get into the wall, the vessels are able to take up these toxins through the vessels and then excrete them. However, if there's lack of blood flow, then these substances cannot be taken up. In terms of alcohol, they are a direct toxin that it can affect the mucosa. Chemotherapy causes destruction of cells, and this destruction tends to be permanent. So because of lack of regeneration of cells, there's a lack of protection. And then we have shock, which basically causes a lack of blood supply, which is important. So now we know why NSAIDs, alcohol, chemotherapy, and shock are associated with gastritis. So how does it present? It presents with mucosal edema, as with hemorrhage and erosions, as I've already said before. But along with that, it also has inflammatory infiltrate, specifically neutrophils. Patients are usually asymptomatic. However, they can have just some nausea and pain with or without hematemesis and melena. However, in alcoholics, patients usually present with major hematemesis. Now we can talk about chronic gastritis. Chronic gastritis is chronic inflammatory changes in the mucosa, which eventually leads to atrophy and metaplasia. Usually patients are asymptomatic, but can cause nausea and vomiting. So there are two main causes of chronic gastritis: Helicobacter pylori and autoimmune gastritis. But as you can see, 90% of chronic gastritis is caused due to H. pylori. The gastritis develops as a result of the enzymes and toxins by this bacteria, as well as chemicals from the inflammatory response of neutrophils. And there are two patterns. We have antral type and pangastritis. So in antral type, it is localized in the area of the antrum, and there's high acid production as well as an increased risk of duodenal ulcers. In pangastritis, this occurs all over the stomach, and there is atrophy, low acid secretion, and an increased risk of adenocarcinoma. In autoimmune gastritis, we have autoantibodies that basically attack the parietal cells. This causes gland destruction and atrophy. Eventually, there's a loss of acid and intrinsic factor, which leads to hypochlorhydria as well as pernicious or megaloblastic anemia. These inflammatory changes consist of lymphocytic cells with some neutrophils and significant mucosal atrophy. There's also possibility to see intestinal metaplasia in gastritis, which is basically replacement of gastric epithelium with columnar and goblet cells of intestinal type. So next we can talk about gastric ulceration, also known as peptic ulcers. So peptic ulcers are chronic solitary lesions that can occur anywhere in the GIT that is exposed to stomach acids. Majority tend to be in the duodenum or the distal stomach. Peptic ulcers usually occur due to imbalance between mucosal defense and damage. It can be caused due to H. pylori and NSAIDs, and we've spoken about why before. And it can also be caused due to increased gastric acidity seen in Zollinger-Ellison syndrome. So what is Zollinger-Ellison syndrome? It is basically when a tumor produces gastric acid. Another cause of increased gastric acidity is cigarette smoking and corticosteroids. In terms of the morphology of ulcerations, they can penetrate into submucosa and often into muscularis propria or even deeper, and they can also present with edema. There are 4 sections that we can divide the ulcer into. So the topmost section of the ulcer, there is a thin layer of necrotic fibrinoid debris. In the second layer, there tends to be a zone of non-specific inflammatory infiltration, and in this case, there's predomination of neutrophils. Under that, there's granulation tissue, and under that is fibrous tissue forming a scar. Patients with gastric ulceration present with epigastric pain that tends to be worse at night, and it's worse few hours after meal. So these people tend to eat in order for their pain to relieve itself. So the patient can undergo significant weight gain. And other than that, patient can also present with nausea and vomiting. The complications of ulcers is the risk of rupture, bleeding, as well as malignant transformation of the ulcer. So now we can move on to gastric tumors. Here we can talk about gastric polyps. So what's a What is a polyps? It's a term applied for any nodule or mass that projects above the level of surface mucosa. Gastric polyps are not extremely common in comparison to colonic polyps. However, they can still occur. The most common polyp is hyperplastic polyp, which arises due to chronic mucosal damage. So once you have chronic mucosal damage, there's a reparative response which causes hyperplastic mucosal epithelium and leads to hyperplastic polyps. This is not a true neoplasm because it is just hyperplastic tissue. The next common gastric polyp is fundic gland polyp, and is basically a small collection of dilated glands, and this is a small hamartoma. And then the last is adenomatous polyp, which contains dysplastic epithelium, and this is the only true neoplasm between the gastric polyps. So within gastric tumors, gastric carcinoma is actually the second leading cause of death, cancer-related deaths in the world, and it has a 5-year survival rate of 20%. There are two types of gastric carcinoma. There's an intestinal type and a diffuse type. The intestinal type arises from intestinal metaplasia, and they tend to be well differentiated, and it is commonly found in the lesser curvature of the antrum. There are many risk factors for intestinal metaplasia, as we discussed before, chronic gastritis. Along with that, there's also nitrites present in foods like smoked fish, infections with H. pylori, decreased antioxidants, which basically means a decrease in fruits and vegetables and a healthy diet, and even possible gastrectomy can be a risk factor for gastric tumor. In terms of genetics, it can also be due to mutation of beta-catenin and HER2/neu. The diffuse type, there are only genetic risk factors, specifically mutation of FGFR2 and E-cadherin. So the most common location for gastric tumors are the pylorus and the antrum, and classification of these tumors are based on the depth of invasion, which means how deep within the mucosa the tumor goes. It depends on the growth pattern, and the growth pattern can be exophytic, which means that it goes outside the mucosa. It can be flat on the mucosa or excavated, so it goes through the mucosa. And it can also be classified by histological subtype, which is the intestinal and diffuse type. In intestinal, we can see basically the formation of interstitial glands. In diffuse, there is no such gland formation. In fact, there is what we call signet ring cells. Patients with gastric tumor tend to be asymptomatic, and only advanced tumors can cause abdominal discomfort and weight loss. Other signs of gastric tumors are lesser Treylat sign, which is basically the presence of dozens of keratosis all over the body, as well as acanthosis nigricans, which is darkening of the underarm. In terms of metastasis, gastric tumors can metastasize to the Virchow node, which is actually another name for supraclavicular lymph nodes. It can also cause Krukenberg tumor, which is spread of tumor to the ovaries, or it can cause Sister Mary Joseph nodule, which basically is a spread of gastric tumor to the pre-umbilical region, and is mostly seen with the intestinal type. So that is all we have for today. I hope that you were able to understand and gain some information. Thank you so much for your attention, and hope you have a nice day.